So, sir, I'll go live. Yeah. So, very good evening to one and all. I, Mrs. Jyoti Nunse, working on with the Hexagon Nutrition. I welcome everyone for our today's second webinar, which is on a transition nutrition, a key elements for recovery and rehab. So today we have a very eminent speaker with us and a moderator with us. I would just like to share their introductory slide. So just give me a minute. Yeah. So my screen is visible, sir?
Yes.
Yeah. So, Dr. Harish sir, he's an intensive care physician and the infectious disease specialist. He's a director, Institute of the Critical Care Medicine from Kaveri Hospitals, Bangalore. Sir is an India's first Medical Council of India recognized as DM in critical care medicine. He had done his diploma in the intensive care medicine from Dublin, and he has more than 15 publications in international as well as a national index journal. Sir is authorized more than 30 chapters in the various academic book. He has received a Young Intensivist Award from Indian Society of Critical Care Medicine. He is an president of Indian Association of Respiratory Care. If we see his research part, he is an editor in chief in the Indian Journal of Respiratory Care. He has also been associated as an editor with the ISCCM chapter, that is a new chapter. He's an esteemed reviewer for the Indian Critical Care Medicine. He's also been a member of the Guidelines Committee for the Indian Society of Critical Care. He has been a recognized teacher examiner for the DNB and the IDCCM, IFCCM students in the critical care medicine. He's a founder and the course director of the master class in the critical care medicine, and which is an online learning platform. He's a very good international speaker for different academic conferences at the national as well as the international speaker. So I welcome Dr. Harish sir for our today's webinar. And to take ahead, we have one more person with us who is a moderator, Miss Ananya Konad. She's an head Department of Nutrition, Apollo Hospital. She's a senior clinical dietitian from Apollo Hospital, Bangalore. She has a deep experience in the nutrition counseling and the therapeutic diets planning. She has been playing a very vital role in improving the clinical outcomes for the patients across the diverse medical specialties. Has contributed extensively to the clinical nutrition research, presenting her papers at the national and international conferences, and she has also received award from the international journals for implementing the ERAS protocol, prebiotic efficacy, and the nutrition intervention in the critical care. She's recognized for her leadership in the quality initiatives, for auditing all the JCI accreditation. She's been known for her compassionate approach and the personalized dietary strategy. She's very committed to her patients' education and the evidence-based nutritional care. Her work of experience, if we say, she has more than 30 years of experience, and she has been including in the prestigious IDA award from Indian Dietetic Association, and she's also been recognized as a national level recognition for the excellence in the clinical nutrition. So I welcome today our both Dr. Hari sir as well as Miss Ananya Konar to take it over to you, sir. Thank you so much.
Give me the sharing option. Yes, thank you. Good evening, all. So maybe in another 35 to 40 minutes, we'll take you through transition nutrition. So why it is a key element in terms of overall recovery and rehabilitation. So I'm going to take you through some of the important numbers where we have a problem in terms of nutrition inadequacy when patient is recovering in the ICU, on the floor when we shifted the patient to recovery room or maybe HDU or maybe in the ward, and from ward to home care. So what is the burden of nutrition deficiency? How we can troubleshoot? So how we can implement with the education, communication to uplift nutrition as a continuum so that we can avoid the burden of deficiency of the nutrition so that overall we can improve the morbidity and mortality. There are lots of benefits. I'm going to discuss one by one in another 30-35 minutes. Okay. So if you see transition nutrition in ICU, why does it matter? So around 38 to 78% of ICU patients are malnourished at admission. So persistent malnutrition is having its own sequelae. Maybe it is inadequate protein energy. Okay. So are combined. So inadequacy leads to increase in nosocomial infection, duration of mechanical ventilation, length of ICU and hospital stay, more chance of readmission. So if you don't concentrate on transition nutrition, so there is a high risk of readmission and the cost involved and overall increase in the mortality. Okay. So current nutritional practice, so oral nutrition preferred whenever feasible. That is a dictum. If inadequate, so enteral nutrition prioritized over parenteral nutrition. So but only around 40% of ICU patients can eat orally. So obviously our main relay of the delivery of the nutrition is through the enteral feeding tube. Okay. So the key concern is even 7 days after extubation, oral intake often remains inadequate. If you see the energy adequacy is around less than 47 to 55% of the target, and protein adequacy is still poor, it is around 27 to 34% of the target day 7 after the extubation. So there is a huge burden. Okay. Again, we'll try to understand oral nutrition after ICU discharge. So this is the transition gap. So the key clinical concern after ICU discharge and cessation of enteral nutrition, many patients fail to meet nutritional target with oral nutrition alone. So if you see the data, so published data, only around 40% of ICU patients are able to eat orally, that already I told. So immediately after ICU discharge, so energy adequacy falls to approximately 47%, protein adequacy falls to approximately around 27%. Okay. So patient receiving, even when they receive combined enteral with oral nutrition supplementation, so then we can little bit achieve energy and protein. So maybe around 50 to 100%. So in terms of energy and like 60 to 80% when it comes to protein adequacy. Okay. So there are lots of major barriers. So why we like have a problem in terms of the transition of the nutrition? Maybe it is because of poor appetite, early satiety, dysphagia, weakness and fatigue, premature feeding tube removal. So this is one of the mechanical problem which have a direct impact in terms of the transition gap. So poor documentation of oral intake, so it's having a clinical impact, as I already told, increased infection, so prolonged ICU and hospital stay, longer duration of ventilation, readmission, mortality and the cost involved. So if you see the data, so this is one interesting retrospective quality assurance study. Okay, very recently we got in Australian Critical Care Journal in 2025. So even though it is a retrospective data which suggests, so few patients had nutritional plan when transferring from ICU to a general ward. So after ICU discharge, percentage of energy and protein requirement so met declined significantly and remained insufficient during the first 3 days at general ward. So this is one retrospective data which suggests, so there is a burden of decreased protein and calorie even at the day 3 after the ICU. Okay. So if you see, this is the adequacy of calorie and protein intake in relation to estimated or prescribed amount in patients who are solely prescribed oral diet in hospital following ICU discharge. So they are still in the hospital, they discharge from ICU. If you rely only on the oral diet, so these are the published data from 2006 to 2021. So almost 1.5 decade data. If you see what we prescribed, what we achieved, significantly low in terms of like protein and that of the calorie when you rely only on the oral nutrition in the like post ICU status. Okay. So this is one more data prospect I study. It is a nutritional adequacy in post ICU hospitalization. Only around 50% of post ICU patient achieved more than 90% of protein target. So oral only nutrition resulted in lowest intake. Prescribed target were frequently under ordered and under consumed. Oral ordering itself is low and oral consumption is also low. So recovery to target intake post enteral neutral discontinuation so took up to 6 days. Okay. So patient receiving supplemental enteral nutrition so have some sort of adequacy. Okay. So basically data is there to support there is a problem in the post ICU era in terms of nutrition like management. Okay, if you see some background, so ICU survival comes with long-term consequences. So overall global mortality is around 16 to 20%. But if you see in India, mortality of ICU patient may go up to 35-40% also. So survivors, suppose if they survived, so they have lots of physical impairment, cognitive dysfunction, psychological morbidity, reduced quality of life, delayed return to work. So this is the impact in the survivors of the ICU. Okay, so we have a some entity, some syndrome called post intensive care syndrome. Remember PICS, post intensive care syndrome. So basically it comprises physical function problem, cognitive dysfunction, and that of the psychological health problem. Together we call it as a post intensive care syndrome. So why nutrition matter in ICU recovery? Okay, it helps in overall functional recovery, muscle strength, cognition, mental length, and that of the health related quality of life. So currently, so nutrition remains an under recognized component in the ICU rehabilitation. So limited representation of nutrition expert in ICU recovery framework. So many of the like patients, once they are in the recovery or HDO or maybe in the ward, so sometimes there is a gap in terms of non-availability of the particular staff to take care of all those things. Significant research gap persists regarding nutrition recovery after ICU. See, most of the data whatever we are having on the floor when the patient is in the ICU, we have lots of data, but post ICU there is a lack of data, lots of barrier. So long term nutrition rehabilitation is lacking. Okay, so if you see overall phases, like when a patient entered into ICU, we have something called pre-admission, so pre-critical illness. So patient already morbidly obese, COPD, okay, so or maybe congestive heart failure or CKD patient, liver dysfunction, lots of pre-morbid, comorbid conditions are there. Then they have some sort of acute insult, so acute phase of critical illness, they are admitted to ICU with or without mechanical ventilation. So when they stayed in ICU for more than 2 weeks, then it become a chronic critical illness which is having its own problem. So if they recovered, so then they go to ward. So from there, they are going to get discharged. That is the post-hospital discharge era. So like you have multiple phases of opportunity to address this nutrition. Either you have ICU admission opportunity, okay. So then they are having acute phase of critical illness, so early recovery phase. So then like you have again in the recovery phase, you can have the opportunity during the ward stay, or you can have a final opportunity during the long term recovery phase when you plan for the discharge. So there are lots of intervention you can do at each level, maybe pre-admission, admission, okay, acute phase, so when they have a recovery, and that of the long term recovery when they are shifted out of the ICU to ward to home. So lots of intervention we can do. We'll try to understand what we can do best. Okay, so why nutrition matter in post ICU rehabilitation? As I already told, so critical illness and malnutrition are closely linked. Okay, so one like parameter which trigger malnutrition is so inflammation as one of the recognized risk factor, which is the major driver of disease related malnutrition. So why ICU patients are highly vulnerable? So because so they have some sort of already pre-existing or like comorbid condition. So there is a acute systemic inflammation, because whether it may be ARDS, sepsis, trauma, everything can kick off infection and that of the inflammation, advanced age sometime, and they are more frail and that of sarcopenic. Okay, so with this they have some sort of metabolic consequences like hyperinflammation, stress metabolism, increased catabolism with the breakdown of the protein tissue, insulin resistance, anabolic resistance will be there. So overall, which result in some sort of the physiological effect with increase in pro-inflammatory cytokines, which lead to accelerated muscle breakdown, loss of lean body mass. Lean body mass is muscle and that of the bone. So reduced immune function when we don't have a protein, because all our immune mediators are protein mediated. Okay, so that leads to poor quality of life with a functional decline. So this is the overall what is going to happen in a critical illness, whether it is a shock, ARDS, sepsis, trauma, whatever it may be. Already they are having some sort of the pre-morbid or comorbid condition. If they require mechanical ventilation, there is a stress inflammatory response. So they are already on some medications like steroid, particularly because steroids are an isolated reason for critical illness, polyneuropathy and myopathy. So when they are undergone some sort of ARDS ventilation, they will be on muscle relaxant like etracurium, vecuronium and all. Again, it is one of the cause for critical illness myopathy. Immobilization because of sedation, prolonged bed rest, limited physical rehabilitation. So then we have some sort of iatrogenic, so undernutrition, inadequate protein and calorie delivery or prescription, whatever it may be. Okay. So that overall leads to increase in resting energy expenditure, increase in protein breakdown. So ICU acquired weakness, as I told, it is because of aminoglycoside, corticosteroid and neuromuscular blocking agents. So with insulin and anabolic resistance, finally, which leads to decrease in lean body mass, decrease in physical function and malnutrition. So this is a complex scenario. Okay. Even though they just had some sort of premorbid and comorbid condition, but because of all these things, finally they land with the malnutrition. Okay. So if you see the magnitude and persistence of nutritional deficit, there are lots of interesting numbers I want to quote here. So rapid nutritional decline after ICU. So within 3 days of ICU discharge, so energy adequacy declined from around 94% to 30%. So protein adequacy, it's less than 50% almost. Okay. From 73% it become 27%. Poor oral intake is common. So 62% of the patients consumed less than two-third of the meal. So 66% consumed less than one-third of the meal. So actual intake after ICU, if you see average oral intake reported, published data, so energy intake is around 10.8 kilocalories per kg per day. Protein intake is 0.4 gram per kg per day. So long-term nutrition deficit, even 12-month post-ICU discharge. Remember, it is not only on the floor, even an year after post-ICU discharge, energy adequacy remained only around 80%, protein adequacy is around 70%. So there is a significant problem on a long run when the patient go home also. Okay. So again, muscle loss is a hallmark of something called post-ICU, like intensive care syndrome. Okay. So why muscle matter? Skeletal muscle constitute around 30 to 45% of the total body mass. So key role of the muscle is it is involved in glucose metabolism, protein turnover, immune regulation, and that of the physical function. So factors which are accelerating muscle loss in ICU: inflammation, oxidative stress, free radical injury, so immobilization, steroid exposure, so inadequate protein and energy delivery, overall, which leads to muscle loss, which is one of the very important hallmark of the post-intensive care syndrome. So key ICU nutrition problem, like critically ill patient develop insulin resistance, anabolic resistance, as I already told. So muscle atrophy is most severe in the first 2 weeks of ICU, because during that time lots of catabolism will be there. So they are in a shock, they require multiple vasoactive agents. Okay. So there are some sort of relative contraindication to feed them in terms of adequate calorie and that of the protein, which together leads to increased incidence of the muscle atrophy. So other than that, so these are some of the data which I want to quote here. If you see the loss of muscle and anthropometric measures, so mid upper arm circumference declined from around 33 to 29 centimeter, approximately 1.6% per day muscle loss happens in ICU. So calf circumference declined from around 40 to 37.5. So another study again 31 to like around plus or minus 4.2 centimeter drop in the calf circumference. So quadriceps muscle loss, so reduction in muscle thickness happened in about 7.2% after ICU discharge. So 30% loss within the first 10 days of the ICU. So another study again it showed so reduction up to 18%. So there is a significant data is available. So critically ill patients on the floor post discharge. So there is a huge loss of muscle mass with some sort of anthropometric measurements. Okay. So again, there is a change in body composition after critical illness. So critical illness causes profound body composition change also. So there is a data on body composition after ICU stay, which is limited data, but available evidence demonstrates significant and persistent weight loss. So ICU survivors with ARDS, 18% of the weight loss as compared to their baseline body weight. So even 1 year after ICU discharge, only around 70% regained their pre-ICU body weight. So weight, there is a problem in terms of reduction significantly even in the weight also. So persistent weight loss after ICU among ICU survivor, if you see, so 40% lost in like more than 10 kg of the weight. At 6 month post ICU, 35% remained at post ICU weight only. So 15% lost Am I audible?
Yes, sir, you're audible.
I lost the network in between. So basically, we can't take weight as a standalone criteria to get an idea about any particular patient, okay, is having a some sort of malnutrition in the post ICU era. There are lots of reasons for that. So body weight is not equivalent to something called muscle recovery, because weight measurement cannot distinguish between muscle mass, fat mass, or that of the fluid changes. Okay. So there is one important observation. Studies suggest that post ICU weight regain is often due to increase in fat mass rather than that of the recovery of the lean muscle mass. Okay. So clinical implication. So loss of lean muscle mass contribute to reduced physical function, persistent weakness, delayed rehab, poor psychological recovery, and reduced quality of life. Okay. So nutrition recovery and rehabilitation after ICU discharge. So what exactly is the nutrition rehabilitation then? So we learned about, okay, there is a loss of weight, loss of muscle mass, and its clinical implication. Okay. It's a big burden. There is no doubt on that. So then what exactly is the nutrition rehabilitation? So nutrition rehabilitation refers to restoration and optimization of nutritional status, so recovery of muscle mass, strength, so functional capacity after critical illness. So the current evidence base, if you see, there is one huge data which included around 16 foundational studies. So the sample size varied from 8 to 193 patients. The studies came from North America, Europe, and that of the Australia. So they evaluated some key areas like nutrition intake, barriers to intake, body composition, physical function, and that of the global nutritional status. So they came up with some sort of conclusion. So major drivers of malnutrition in ICU survivor, we have lots of biological effect of critical illness, which I already described. So there are some organizational and process factor. Okay. So premature feeding tube removal, very, this is one of the big culprit. So poor transition planning, so inadequate nutrition monitoring, so lack of structured rehabilitation pathways. So we don't have a SOP on the paper to follow. Okay. So third point is nutrition knowledge and awareness. So under recognition of nutrition deficits, so limited nutrition expertise in recovery pathway. There is no availability of the dietitian or nutritionist. So variable clinical awareness regarding the post ICU nutritional needs. So these are some of the barriers. Okay. So together we can have something called biological barriers of nutrition intake during post ICU recovery, and there are some non-biological barriers. We'll try to discuss one by one. So when it comes to biological barrier, we have physiological barrier. See, most common barrier is poor appetite. So most consistently reported in the post extubation era, so can persist for several months even after ICU discharge, so which is associated with reduced dietary intake, increased comorbidities. So other common physiological barriers are early satiety, nausea, vomiting. Okay. So or maybe altered taste, that we call it as dysgeusia. So then second biological reason is functional barrier. So many patients can have oropharyngeal dysphagia, so which is one of the major contributor to poor intake after ICU. So up to 84% of post extubation patients may develop like oropharyngeal dysphagia. So again in tracheostomy patient, so the prevalence ranges from around 10 to 83%. So the clinical consequence of dysphagia, malnutrition, prolonged stay, increase in mortality. Okay. So again, like nutrition challenges with dysphagia diet. So we need some sort of modified diet, pureed food, okay, thickened liquid, reduced calorie intake, reduced protein intake, increase in malnutrition risk when we go for adjusting for this dysphagia and all. There is the one of the functional barrier, which is one of the important biological barrier. Okay. So then other entity, as I told, ICU acquired weakness. So reduced ability to self-feed because of the myopathy, reduced dietary intake. So the data suggests approximately one third of ICU survivor. So with ICU stay more than 2 weeks, so they have some sort of ICU acquired weakness. So they were not able to feed themselves independently even 6 months after the ICU discharge. So third barrier is psychological barrier. So common psychological issue, depression, anxiety, post-traumatic stress disorder, low mood. Okay, again, it is having an impact in terms of the nutritional recovery. So these are some of the biological barriers. So what are the non-biological barriers, which are very, very important? Okay, so we have some sort of organizational barrier. So hospital-related factors frequently impair adequate nutrition intake during the recovery. So common challenges are meal delivery at inappropriate time. So there is no match of the need of the patient and that of the delivery time. So missed meals and that of the snacks. So interrupted meal time, lack of flexibility in hospital meal schedule. So some hospital they will tell, okay, we give food in this particular time range only. After this, we are not bothered. So if you have a lack of flexibility, that is an organizational barrier. So why this particularly affect ICU survivor? So post ICU patients commonly experience altered sleep pattern. Okay, when they are awake, so we need to be flexible to feed them. Okay, poor appetite, early satiety, fatigue, weakness. As a result, so rigid hospital meal system often fail to meet the patient need. So care transition again add to further risk. So they are moved from ICU to ward, hospital to home or rehabilitation, which can disrupt continuity of nutritional care and recovery planning because the team is changed. The clinician, primary consultant is different. So then lots of transition gap will be there when they shifted from ICU to ward. So or maybe like ward to home or that of the rehab center. So again, other non-biological barrier, very, very important is healthcare provider knowledge and out of the communication gap. So there is a challenge during ICU transfer, lower nurse to patient ratio as compared to ICU in the ward. Again, the ratio is going to be very, very poor. So team with limited expertise in post ICU recovery care, they are not bothered about, they are not trained about the nutrition care and all. So common nutrition care problems are poor communication of nutrition care plans, so under recognition of post ICU nutrition need. So nutrition viewed as a lower priority than giving an antibiotic. Okay, so premature removal of nasogastric feeding tube often before so dietetic assessment. Again, it is having an impact on the overall recovery when we have a poor knowledge than that of the communication. Okay, so nutrition intake during recovery, after critical illness, and on the floor before shifting to home is having lots of like some sort of the impact factor. If you see, nutritional intake is frequently inadequate in ICU survivor because of many factors which I told. So calorie and protein intake after ICU discharge. So patients dependent only on oral nutrition. So they have like lots of problem during the early ward based recovery phase. Patient receiving only oral diet, so typically achieve around 50 to 70% prescribed calorie, around 27 to 70% of the prescribed requirement, which is having its own consequences. So impact of continuing enteral nutrition. Okay, so patients receiving enteral nutrition, so with or without oral nutrition perform better. Remember, so tube feeding with oral feeding, they perform better. There is a data available. So patient who continued enteral feeding with or without oral intake achieved around 60 to 104% of the prescribed calorie. Okay, and around 60 to 100% of prescribed protein target. So why this matter? So continued enteral nutrition with oral nutrition improve the nutrition adequacy, reduce protein deficit, support muscle preservation, and facilitate the recovery and that of the rehab. Okay, so again, nutrition intake. So following hospital discharge in ICU survivor. Again, if you see the data, this area is limited studies because nobody is bothered when patient is discharged home. So we don't have proper like some sort of randomized control trial to look into this area. As long as they are on the floor, we can gather some sort of data and we can publish. But when they go home, hospital discharge happened, so that data, that evidence is limited. So only few studies have evaluated calorie and protein intake after ICU survivor. So return home. So highlighting a major knowledge gap in long-term nutrition recovery. So key finding at 3 month post-discharge, very, very important. So patient receiving structured rehabilitation support. If they have a SOP written in a structured way, which achieved around 113% of estimated calorie requirement and 90% of estimated protein requirement. So usual care, they don't have a structured rehabilitation support, so then they achieved hardly 70, around 69% of the so protein and that of the calorie like requirement. This is the available data, even though we don't have a huge data, but few studies which showed, so there is a problem between structured rehabilitation support versus that of the usual care. So what pragmatic strategies to enhance nutritional recovery in ICU we can do? So in the survivors, so we need to consider this, because like lots of challenges in the post ICU recovery, and we need to preserve the muscle in that era. Okay, so we should follow something called patient centered nutrition care, not like shift, like we need to have a shift from service centered to patient centered care. So nutrition care should focus on individualized need, so values and preferences, so functional limitation, and what recovery goal we want to achieve in that particular patient. It is not something like you have some sort of service centered, okay, I have given the feed, that's end. It's not like that. We need to have a patient centered individualized plan. So core component of patient centered nutritional care, so recognizing the patient as a person, not just as a diagnosis. So shared decision making with patient and that of the family. So providing individualized nutrition education. So setting realistic nutritional goals and that of the target. So continuous reassessment and feedback should be there. Okay. So optimizing, so recovery environment, like simple practical intervention. So flexible meal timing, like we can consider later breakfast for patient with a poor sleep, so protected meal time, so minimizing meal interruption, so encouraging patient to eat at table or chair instead of bedside when feasible, when they are allowed to mobilize. So family engagement is very very critical, so they can assist with feeding, encourage oral intake, maintain the food diaries or food log, so maintain advocate the nutrition care, and provide social, so facilitation of eating. Family involvement so makes a difference in terms of achieving the nutritional goal. So strategies to improve nutrition recovery in ICU survivor. So healthcare provider education, very very important. So ward staff often should get educated, because that is one of the under recognized area. So education should focus on like common post ICU barriers, including poor appetite, early satiety, taste changes, weakness and fatigue. So delirium, that is one of the problem. Patient is psychotic, so then they are not bothered about the feeding, they are worried about their restrainment and all. So anxiety, depression, so post traumatic stress disorder, all these things education should be provided. So who require the training? So particularly nurses, physicians, newly joined dietitians, so and that of the rehabilitation teams, like physical rehabilitation teams. So nutrition education should be integrated into graduate training, postgraduate critical care education. So ward based rehabilitation program should be conducted. Okay, so again improving care transition. So transition from ICU to ward is a high risk period, so poor communication during transfer can compromise nutritional rehabilitation. So essential component of nutrition handover plan, very very important. So in many hospitals they don't like follow this nutrition handover plan. So clearly documented information should include current nutrition intake, oral nutrition, enteral, parental, that documentation should be there. So physiological barrier, as I already told, that should be documented. Psychological barrier should be clearly communicated. Food preferences, dislikes, okay. So family involvement in feeding support, all these things should be so communicated, and it is strongly recommended for overall improving the recovery of the nutrition. Okay, so transition from hospital to home, again nutrition recovery after ICU. Why discharge planning matter? Because ICU survivors are complex. Okay, they are not simple. So nutritionally vulnerable. So population which requires structured discharge planning, continued nutritional rehabilitation, long-term multidisciplinary follow-up. Okay, so there are some key components we can follow up in the post-ICU nutrition discharge plan. So tailored nutrition advice. So we can advise on calorie dense if they are a CKD patient, like protein rich nutrition, so oral nutritional supplementation, strategies to overcome poor appetite and that of the fatigue. So continuity of nutrition care is very very important, so clearly should be communicated at discharge. Transfer to community dietetic service, so this is not available in Indian scenario. We don't have a community dietetic service. So monitored like during the recovery, with each visit we should document all those things when they got discharged home. Okay, so role of post ICU recovery clinic, again, so these are some hospital, some quaternary tertiary care center, they follow something called post ICU recovery clinic. So critical care recovery services, which is a multidisciplinary outpatient follow-up. Okay. So physical rehabilitation, psychological support, functional recovery, we can consider if we see the teams involved. So one of the team is dietitian. Okay. So with a clinician, with a nurse, physiotherapist, pharmacist, and psychologist in the post ICU recovery clinic. So dietitian is having a major role. So that is something we need to look and we need to think in a tertiary quaternary referral centers. Okay. So looking forward, so what are some of the research opportunities in the post ICU nutrition rehabilitation? So current state, so we have a limited data in the post ICU nutrition rehab. Okay. So as I already told, so which is underdeveloped, so largely unexplored. As long as they are on the floor in the hospital, we have a data, but once they got discharged, we don't have a data. So major need is like longitudinal studies are required to evaluate nutritional recovery from ICU stay through hospital discharge into months and years of survivorship and that of the follow-up. Okay. So key research priorities, understand the nutritional requirement. So identify the barriers and that of the facilitators. So potential future nutritional interventions. What we can think of, like in a indicated patient, we can think of branched chain amino acid. So like beta hydroxy, beta methyl butyrate, HMB based. We know that HMB is having a role in preserving the muscle. So it helps in improving the mitochondrial function. It helps in reducing the free radical injury and all. So creatine supplementation, again, lots of like some studies are ongoing in this area. Anti-inflammatory nutritional therapies, appetite regulating strategies, so gut brain axis modulation. Okay, because so there is a link between the gut and that of the psychological status of the patient. So all these things are the future nutritional interventions we can potentially look for. So combined nutritional model should be there. So nutrition therapy plus physical rehabilitation exercise program, because combined approaches may improve muscle mass, strength, and overall functional recovery. Okay. So this is some sort of anecdote, some sort of like the practical overview how we can address this, how to transition from tube feeding to oral feeding. Okay. So determine if patient is a candidate for SLP, sleep language pathology assessment. Okay. Swallowing assessment. So alert enough to follow simple command, maintain upright position for more than or equal to 30 degrees, like head and elevation, no obvious barrier to eating or drinking. So then like you can straight away feed them. So unable to follow the simple command, okay, means you can assess for the swallowing in these three criteria. So unable to follow simple command, unable to maintain the upright position, obvious barrier for eating or drinking. So then you have to be careful. Okay. Remember, altered mental status isn't an absolute contraindication for swallowing assessment. So they can be irritable for many reasons. You can still go ahead with the swallowing assessment. So next is perform a swallowing assessment. Okay. So patient who need an evaluation by SLP. So sleep language like pathologist SLP is like those who are having a history of dysphagia, need for texture modification, prolonged intubation. If they got intubated for more than 2 days, so those patients with a tracheostomy, high flow nasal cannula, increase in oxygen requirement, facial droop, inability to manage saliva, so recent head and neck cancer or cervical spine surgery, they definitely need SLP assessment. Okay. So none of these factor, so none of these risk factor, then you can go for 3 ounce water swallow challenge. So you give a 3 ounce water in a sequential swallow. If they pass, if they are able to swallow regular solid, then so liquids like we can follow. If they fail, okay, there is a interrupted drinking. So there is a coughing while drinking, throat clearing they are doing. So wet or gurgly voice. So then they failed SLP evaluation. So then you need to wait for giving them orally. So then continue the tube feeding. Okay. So next step is start the patient on a diet and monitor orally. Whether it may be cyclic, intermittent, or bolus, you should start and make a table in terms of particular day. Okay, how much percentage it is satisfied with breakfast, lunch, dinner. Okay, and how much you need to supply them. So then like assess the oral intake and adjust the tube feeding. So you taken into consideration of calories provided by diet or oral feed. Okay, then overall requirement and how much you need to adjust through the tube feeding, that you need to adjust. Okay. So again, so like this is one data which you can follow. Approach to adjusting tube feeding based on percentage energy need met with the diet. Suppose assume like less than 25%. So it is being achieved with the diet. So then what you need to do is meet more than 80% of the estimated energy with the tube feeding. And again, so consider an add-on oral nutritional supplementation and that of the snacks. If the energy need met with the diet is around 25 to 50%, then around 50% you need to satisfy with the feeding. If the satisfaction with the diet is around 50 to 75%, meet the remaining 25% with that of the tube feeding. If they are already satisfied with more than 75% with the oral diet alone, so then hold the tube feeding, prepare for removal of the rice tube if you are satisfied. So that is one way. Okay. So next what you need to do is continuously monitor. So okay, then assess and adjust the add-on oral supplementation or that of the tube feeding what you need to consider. So continue to monitor and assess oral intake. So document percentage of meals or supplements consumed. So provide feeding assistance and encouragement. Obtain new weight measurement. So monitor urine and that of the stool output. So overall, so monitor, assess and adjust. So that cycle you need to continue. So it's a dynamic process. So provide a meal, observe the intake. So remaining you satisfy with the tube feeding. If tube feeding, if you are able to cut down by 25%, means it is requirement is 25%, 75 to 80% they are satisfied with the oral intake. So then you can think on removal of the rice tube. Again, this is the route map. So route transition ICU. So in terms of parenteral to enteral and to the oral nutrition, you can just go through. So when patient is acute unstable is in ICU, we need a separate plan. So gut usable but oral is not possible. So then obviously we go for enteral feeding. So enteral feeding is inadequate. Then we think of supplemental parenteral nutrition. So extubated but poor intake. Then we continue enteral nutrition with a trial of oral nutrition, improving oral intake. So then we take a call whether we can pull out the tube when they satisfied with the oral intake of more than 60 to 75%. Okay. Again, this is the transition table from enteral to oral feeding transition checklist. What you need to look. So swallow safety, oral intake trial, calorie count, protein adequacy, functional ability. Means patient can sit, chew, swallow, self-feed, all those things you need to assess. And GI tolerance. So then you take a call on removal of the tube. So do not remove feeding tube just because patient is extubated. Remove only when oral intake is proven adequate. That is around 60 to 70%. So which the need is satisfied. Okay. Again, this is the ICU to ward transition, ward to home nutrition rehabilitation plan. You can just go through all these tables, which we already discussed. Okay. So overall, in a simplistic way, in a critically ill patient, how we can approach. So is gut unusable? If the answer is no, so you go for parenteral nutrition or supplemental parenteral nutrition. If gut can be usable, okay, there is no absolute contraindication, then start enteral tube feeding. So extubated, patient is conscious, recovering, so swallow assessment done. So we can try with the oral trial. His oral intake is more than or equal to 70% of the calorie and protein target for at least 2 to 3 days. So if the answer is no, then continue enteral nutrition, that is tube feeding with or without oral nutrition supplementation. If the answer is yes, they are satisfied more than 75%, remove the tube and continue oral diet with that of the oral nutrition supplementation. So then we should have a ward discharge plan, home nutrition rehabilitation with dietitian follow-up. Okay. So again, this is the table. So this is ICU protocol for transitioning from parenteral to enteral nutrition. So this in a stepwise manner, you can just go through it. So this is the transition from enteral nutrition to oral feeding. So stage 1, so assess the patient readiness. So initiate interdisciplinary collaboration, that is a stage 2. So in the stage 3, so develop individualized plan. So in terms of the transition plan, so implement and monitor. So then finally evaluate and complete the transition. So which we discussed already. So how to go ahead. So from parenteral to enteral to oral, from ICU to ward to discharge. So these are the two transitions which we are going to do. So again, so is there any role of oral nutrition supplementation? Is it a missed opportunity in recovery? So definitely yes. If you see post ICU patient commonly suffer from poor appetite, swallowing issue, early satiety, delayed gastric emptying, and reduced gut motility. Okay, where if you are able to complement with the oral nutritional supplementation, which is going to improve general well-being, reduce protein breakdown, decrease post-operative insulin resistance. So strongly recommended even from that of the ERAS protocol and all. Okay. So oral nutrition supplementation. So this is the data, one of the data, large data. So definitely which helped in overall improvement and reduction in the morbidity and mortality. So lastly, so this is one of the pragmatic strategy for delivering adequate protein and energy across critical illness and recovery phases. Maybe in the acute phase, in the ICU, okay, post ICU phase, post ICU phase extended, and post hospital discharge. So this is what we discussed already. Okay, so we can just go through this in terms of transition care so that to reduce the morbidity and mortality. So the takeaway, so transition phase. So parenteral to enteral, enteral to oral, ICU to ward are vulnerable points where nutrition gaps often occur and must be proactively managed. So adequate protein intake is crucial throughout the critical illness and recovery to preserve the lean body mass and support immune function and enhancing healing. Okay. So effective communication, multidisciplinary collaboration are key to ensuring continuity of nutrition care post ICU. Post ICU oral intake is often inadequate. So structured monitoring and use of ONS are so underutilized opportunities to improve recovery outcome. So guideline based patient centered nutritional strategies must be implemented to bridge the gap and enhance long term outcome. Thank you all.
Thank you, Dr. Harish, for the excellent and highly informative session. You have actually beautifully highlighted the importance of transition nutrition, its role in recovery and rehabilitation, sir, especially in the ICU settings. So I could actually imagine myself in the, going in the morning rounds and, assessing the patients, looking at their calories, the deficit, and trying to adjust the deficit by giving the oral nutrition. I am sure the audience also have found the session extremely valuable and clinically relevant. I would request the participants to type on their questions so that I can read them one by one. Sarah, can I read? There are few questions on the chat box.
Yeah, there is one question on HMB in transition
Yeah,
nutrition. See,
creatinine and HMB.
yeah, so nowadays data is there on HMB. So there are some commercially available products which are already included HMB in their like content. If you see the recent data also, as I already told, uh, so there are some molecular level studies also happened. So HMB helps in preserving muscle. Okay, it helps in improving the mitochondrial like function. So it prevent the protein breakdown with that of preventing the oxidative stress, oxidative injury and all. So data is evolving, but definitely, so this is one area we can look in terms of some clinical outcome benefit with lots of like RCTs unwinding in the coming years. So one more question on minerals, both oral and IV used in ICU survivors. See, basically, like trace elements are a part and parcel of any nutrition therapy. So many of the trace elements and minerals they act as a cofactors for many of the pathways, metabolic pathways, particularly glycolytic pathway and all. So they need to be considered, but many of the like formulas which are available, they have some sort of inbuilt availability. So, but only thing is whether additionally supplement like trace elements and all. So in a patient with the oncology background, or if they are having a mechanical problem pre-existing like CA esophagus, so obviously we can expect the entire overall like poor intake in such patients are post chemotherapy, so post radiation enteritis, or where we can expect lots of catabolism and all. In those patients we can consider an IV supplementation of the trace elements including the minerals and all. So again, one more question, like as dietitians, we are not in control of these decisions, like
Control, yes.
yeah, when to remove tube
When to
or
remove.
progression. But I think definitely, see, basically, this culture change started already in the last 5 years. Okay, so if you see in many of the ICUs, so by default, even though patient is having a oral rice tube in my ICU, I'll tell. So we put like we change the relative from oral to nasal, so we extubate. We don't remove like both together without any nasal relative and all. By default, any patient, whether patient is young, adult, elderly, head injury, it's not only for stroke patient. So by default, if they are having a oral relative, we make it nasal. Okay, then like we extubate the patient. So when should remove the nasal, we don't jump. See, many a times like we get a input from surgical colleagues. Okay, they themselves very eager to pull out the tube and all. They tell, okay, okay, hello, hello, orally. So like half idli, half cup of juice, 2 spoons of scoop they take. So then they are very hurried to remove the rail tube and all. So we'll tell them, okay, we quantify. Okay, we'll tell. So not adequate. So it is too early to take out the rail tube and all. So that is some culture change is happening in the last 5 6 years. Maybe another coming with this kind of activities, with dissemination of knowledge, with interaction and all, definitely it's going to happen. See, at least the concept of nutrition came into enlightenment in the last decade. Maybe another 4 5 years, the concept of like transition nutrition will come into picture. No doubt on that.
Yeah, true. So in our hospital also, sir, when once there is a transition from your enteral to the oral, probably when the Riles tube is, we don't remove the Riles tube, as you said. We
Yeah,
start giving them lot of protein, oral protein supplements, try to understand whether the patient can, and then probably a full-fledged semi-solid to soft diet is what we plan here.
yeah.
Daphne ma'am, if you have any question to sir, you can unmute and ask. Daphne ma'am, yeah. Ma'am, are you there?
Can you hear me?
Yes, Daphne ma'am, I can hear you. If you have anything, so it's still there.
Yeah. No, doctor, I'm asking generally.
Yeah.
It's not the question of when to remove the tube. I'm saying we are not in control of that.
Yeah, that I got definitely, because the problem is they will not taken your input at all. So then that is a
Yes.
problem. So
Yeah.
science is there, science everyone is aware, but the problem is that inclusiveness in terms of decision making, that is not
Yes.
happening.
Yes.
So that is
Yeah.
what I mean. See, basically,
So we are
maybe
mostly involved. Like, okay, the tube is removed.
you okay?
The ICU dietitian, please quickly come and assess.
Uh-huh.
We are. So I'm say okay, like you said, transition is happening, but
Mm.
I just wanted to throw light on that.
Yeah, one thing is, see, like one area which less explored, as I already told, no, like so beyond hospital. So if you see in any metro cities, particularly like Mumbai, Bangalore, even any of the metro cities, lots of rehab centers they started. Okay, like for
Yes.
neuro,
Yes, sir.
non-neuro, and even in Bangalore also, like son daughter settled in US, patient is critically ill, so there is no question of taking them to home. So they
That's
go to
true.
the rehab center, whatever the illness,
Yes.
minimal or
Yes. Yes.
maximum. So that is one area, maybe as a public impact, maybe like as a society is when you can conduct some sort of like survey, or maybe some sort of education activity targeting those rehab centers. Because see, our practice is, I practice like this. It is not like I am the primary till the end of discharge of the patient. Means once patient got admitted in the ward, also we follow up, and again they come for the OPD follow up and all. So in that way we know that like where the patient went. Because in many ICUs it's not going to happen. Intensivist on the floor, once his job is done, so then it get transferred under some primary consultant. So then we don't know, intensivist don't know what exactly happened when patient gone home or to the rehab center and all
To
that
the ward
disconnect.
also. Yes. Yes.
Yeah. So
Yeah.
maybe because this rehab centers nowadays, if you see, like many are coming, like many people every week they come, they tell, sir, we started this one. I don't know what's happening in terms of nutrition therapy. They might be having some in their panel, some on-call dietitian or something might be happening. But this area, as a society, you can think like what we can do, getting some feedback, some training or something in that area also.
Yes, sure.
Yeah.
So,
Thank you. Thank you.
Thank
thank
you.
you, Daphne ma'am. Sir, what can you just highlight few points on immunonutrition during recovery?
See, basically, when we call it as a immunonutrition or a pharmaconutrition, no? So this is the component which we don't use for calorie purpose. It is beyond the caloric value. When we call it as an immunonutrition, basically we think of immune modulation in a favorable way. Like, okay, we want some sort of free radical scavenging, and we have something called in the immunonutrition. So defined immunonutritions are glutamine, arginine. Okay, so then we have omega-3 fatty acids. So these are three entities in terms of the immunonutrition. So what about glutamine? See, we got lots of data. So if you see the theoretical rationality for glutamine, so glutamine acts as some sort of fuel for rapidly proliferating cells like enterocytes, fibroblasts, and all those things. And it is involved in something called galt and malt. So gut-associated lymphoid tissue, mucus-associated lymphoid tissue. So they assumed it prevent the translocation of gut organism into the bloodstream, which helps in providing some nucleotides. Okay, so which helps in glutathione peroxidase, which is a free radical scavenging agent. This is a theory for glutamine. That is a immunonutrition. Okay, but the problem is if you see all the data in the last 2-3 decades, data comes so in like patients who are having a burns and trauma where there is a utility of the glutamine. So we got a one landmark trial that is called Redox trial, where they tried to give both oral and that of the IV glutamine. Okay, so then they land up with significant increase in the incidence of mortality and that of the renal dysfunction. Okay, so the take home on glutamine, do you think like glutamine is totally out? No, but if we have some sort of modality to measure the glutamine level, like how we measure potassium, sodium, and all, so definitely we can take a consideration on extra glutamine supplementation. But otherwise, in general, all critical ill patient externally to give glutamine, answer is no. Maybe trauma, burns, and onco critical care unit where we have a problem, mechanical problem, then you can consider glutamine. So again, when it comes to arginine, okay, so arginine, we know that theoretically it is involved in wound healing, proline synthesis, collagen synthesis. Okay, so again, on the other hand, arginine is also involved with so nitric oxide, peroxynitrate synthesis. So nitric oxide is a potential vasodilator. So in sepsis, we know that sepsis is a vasodilatory shock, distributive shock. So where is the question of giving arginine in sepsis, which is already a vasodilator shock? Answer is no for arginine in critical ill septic patient. So maybe to some extent in surgical patient to hasten the wound healing. So anastomotic leak prevention, we might be having some role of arginine. Again, when it comes to omega-3 fatty acids, like we have icosapentaoic acid, docosahexaenoic acid and all. So data is there. It helps in preventing like pro-inflammatory cytokines. So that is a major advantage. But omega-3 fatty acids, major data came with acute lung injury and ARDS patient. But among these three, so can we use omega-3 fatty acids? Yes, maybe for all critical ill patient. Can we use glutamine for all patients? No, as an add-on supplement. So can we use arginine supplement as an add-on? Answer is no. In a particular patient, we can consider. So these are the three pharmaconutrients or immunonutrients, like already dissected too much and lots of guidelines, given a clarity where to fit, where not to fit in general ICU patients.
Sir, one question from my end, I really wanted to talk to you about. What about post-ventilator patients? Because and even for prolonged sepsis patients, what is your take on the nutrition part?
See, immunonutrition, you mean?
Yes, sir. Immunonutrition or the total thing, because post ventilator patients, it is actually a challenge. Even for sepsis, it's actually a challenge in meeting up the requirements. How do you suggest us going about with it?
You see, basically, any critical ill patient who got ventilated, sepsis as a reason, or maybe ARDS or a polytrauma and all. So definitely there are hypercatabolic protein loss, everything will be there. So
Yes.
the goal initially, So to match maybe around 50 to 65% of their calorie in the initial 3 to 5 days up to 7 days. Okay, we are not bothered about 100% requirement. So then protein somewhere around 1.2 to 1.3 grams if you are able to match. So then that is sufficient. But the problem here is like many patients who are unstable hemodynamically, they are requiring noradrenaline, okay, adrenaline, vasopressin and all. So one myth most of the people what they follow is okay, patient is on NARA, don't feed them. So that is the myth actually. So data is very clear. So if they are on moderate dosage of norepinephrine or vasopressor agent, even on mechanical ventilator with sepsis ongoing, we can go for something called trickle or tropic feed. There is no absolute contraindication for those patients who are on like some sort of vasopressor agent because see, like it is not the question of gut ischemia there. So question is it is the redistribution of blood. If you feed them, so there is a blood supply requirement which is going to happen towards the gut. That was the reason. But most of the meta-analysis systematic review which clearly told, so there is no worry, we can go for like some sort of tropic or trickle feed, maybe 20 ml 25 ml per so hour that we can feed. So but our achievement is like requirement is not too huge in the initial phase, particularly when it comes to calorie. So I think that prudently we can match. So if you don't follow, okay, patient is unstable hemodynamically on vasopressor, we are going to totally stop. If you don't follow like that, so then we can achieve in a stepwise manner.
So, one of the panelists, the attendees wanted to know if there are good books or articles which you can refer to. And I can see this Sir's scanner is also here. Sir actually has wonderful sessions on critical care. So you can scan the QR code and attend Sir's classes. Any books or articles which, Sir, you can refer to
Yeah,
us?
there are many, see, other than guidelines, okay. So other than like ESPEN, ASPEN, Canadian, or maybe Indian Society Consensus Guideline, there are lots of review articles are there. So my suggestion is go for review articles which take from basic pathology, okay. So then to the management and it criticize on the current existing evidence. So that is how you can improve your knowledge in any area. So review articles from JAMA, so maybe NEJM, so CCM, ICM. So there are lots of things are there. So then maybe in your closer group, I'll try to post a couple of things. I have a huge material. So huge material in the last 1.5 decade. I'll share that one.
Thank you so much, sir. So okay, as we come to the end of today's webinar, I would like to express my sincere gratitude to our speaker, Dr. Harish Malapura, for sharing his valuable knowledge and practical insights with us. Thank you so much, sir, for making the session so engaging. Now, I also want to thank uh, Clinical Nutrition Excellence Academy, ISPEN, and Hexagon Nutrition for organizing this educational initiative. Finally, a heartfelt thank to all the participants for your active presence and participation. We hope you today's session has added value to your clinical practice and encourages continuous focus on nutrition as a key component for recovery and rehabilitation. Hope you all had a wonderful evening. Thank you and goodbye. Good night to all. Thank you, sir. Good night.
Thank you. Thank you all.
Thank you,
Thank
sir.
you. Yeah. Bye-bye.
Bye bye, sir.